Hello everyone in Cardiomy's channel, and with the last video in the guidelines of ventricular arrhythmias, and we have a long topic today about the ventricular arrhythmias in some miscellaneous diseases that are less common than ischemic dilated cardiomyopathies and the other examples that we mentioned in the last videos. What are we trying to cover today in this video? We are covering LV non-compaction cardiomyopathy, restrictive cardiomyopathy with a special emphasis on cardiac amyloidosis, neuromuscular disorders like myotonic dystrophy, Duchenne Becker dystrophy, inflammatory heart diseases like myocarditis, cardiac sarcoidosis, and Chagas disease, and last, valvular heart diseases. We are covering here the management of ventricular arrhythmias per se in these diseases, not the whole management of these conditions. Also, we will cover ventricular arrhythmias during pregnancy, before and after heart transplantation, and the ICD decision in elderly, but in brief. Let's start with LV non-compaction cardiomyopathy. This is a disease of endomyocardial trabeculations that increase in number and prominence with a high risk of ventricular arrhythmias, thromboembolic events, and LV dysfunction. Genetic testing here has a low yield, and regarding risk stratification in a meta-analysis including about 2,500 patients, it revealed a risk of cardiovascular mortality similar to that of dilated cardiomyopathy regardless the extent of trabeculations, and the detection of fibrosis using CMR here in patients with preserved ejection fraction was still associated with serious cardiac events. That's why the task force recommends that the decision for ICD implantation for primary prevention in those patients should be the same as the dilated or hypokinetic non-dilated cardiomyopathy recommendations. Let's remind ourselves with these recommendations. ICD is indicated for primary prevention in those with symptomatic heart failure, ejection fraction less than or equal 35%, with more than or equal 3 months on optimized medical treatment, and also in those with ejection fraction less than 50 and 2 or more risk factors like syncope, late gadolinium enhancement on CMR, inducible VT at programmed electrical stimulation, or the famous pathogenic mutations. Let's move now to the restrictive cardiomyopathy. It can result from infiltrative disorders like cardiac amyloidosis, in which there is low voltage QRS complexes due to interstitial deposition causing compression of the myocytes, or storage disease like Anderson Fabry Disease, in which there are voltage criteria of LVH due to the intracellular deposition of the substance causing myocyte hypertrophy. The consequence is heart failure with preserved ejection fraction. A famous example is the Anderson Fabry Disease, which is an X-linked lysosomal storage disease due to deficiency of alpha-galactosidase, resulting in deposition of glycosphingolipids in the vascular endothelium and the epithelium of these organs like the skin, eye, kidney, heart, and the brain and peripheral nervous system. In a recent systematic review of this disease, including 4,185 patients, the majority of reported cardiovascular deaths were due to sudden cardiac deaths, and the risk factors included higher age, male gender, presence of LVH echo, degree of late gadolinium enhancement in CMR correlated with the extent of fibrosis, and the presence of non-sustained VT. However, the retrospective nature of these small single-center studies and the low absolute number of cardiovascular deaths did not allow any guidance for primary prevention ICD implantation. That's why there are no specific recommendations for ICD in those patients so far. Another infiltrative disease is amyloidosis, characterized by interstitial deposition of misfolded precursor proteins, which can result from light chain amyloidosis called AL due to multiple myeloma, usually in the elderly, AA, which is secondary to chronic inflammatory disease, for example bronchiectasis, and TTR amyloidosis called transthyretin, which is either a wild type complicated by AV conduction delay and atrial arrhythmias, or the hereditary type due to pathogenic mutation in the TTR gene. Of course, because we are speaking about cardiac amyloidosis, so AA is not a famous cause of cardiac affection, while light chain and TTR amyloidosis are the most two common examples causing cardiac amyloidosis. The problem is that the clinical outcome is still poor in those patients with cardiac involvement due to progressive heart failure, autonomic dysfunction, and electromechanical dissociation. But still, the benefits of primary prevention ICD in those patients raise a question mark because there are no clear recommendation. But so far, an ICD should be considered in patients with light chain or TTR amyloidosis with hemodynamically non-tolerated VT, still class 2A, and after careful discussion, of course, of the competing risk of non-arrhythmic deaths, which can result from heart failure with preserved ejection fraction, and the non-cardiac deaths due to other organ affection, like in case of multiple myeloma, causing acute kidney injury, hypercalcemia, or immunodeficiency. That's why the decision for ICD implantation in patients with cardiac amyloidosis should be considered by a multidisciplinary team assessing the overall condition and the risk of mortality in those patients. Let's move now to the neuromuscular disorders. Most of them are associated with conduction abnormalities or sometimes tachyarrhythmias, which may be life-threatening and with mechanisms that are amenable to some specific antiarrhythmic drugs. That's why we are discussing them here. The most famous example is the Myotonic Dystrophy, which is the most common muscular dystrophy in the adult population. Duchenne Dystrophy, which is an X-linked autosomal recessive disease with a high incidence, about 1 in 3,500 male births, rarely seen in adulthood because most patients die before the age of 20, and Becker Dystrophy, which is slightly less common, with some patients may reach adulthood. The general recommendation so far is that annual follow-up with at least 12 lead ECG is recommended in patients with muscular dystrophy, even in the concealed phase of the disease, due to common presentation for conduction disorders or tachyarrhythmias sometime, and patients with neuromuscular disorders who have ventricular arrhythmias or ventricular dysfunction should be treated in the same way for arrhythmia as in those without neuromuscular disorders. And here, of course, the benefit of ICD should be balanced against the overall prognosis in some subtypes, as we mentioned before. The EP study is indicated in patients with myotonic dystrophy with palpitation or syncope suggestive of ventricular arrhythmia or survivors of a cardiac arrest, also in cases of sudden increase in PR interval or QRS duration regardless the absolute value that it reached, and still indicated in those with PR interval more than or equal to 140 milliseconds or QRS more than or equal 120 or older than 40 years and having supraventricular arrhythmias or older than 40 years with significant late gadolinium enhancement on CMR. And don't forget that HV interval more than or equal 70 milliseconds should prompt pacemaker implantation regardless the symptoms due to high risk of AV block. In some patients, they may have induction of bundle branch reentrant VT, in which case catheter ablation is recommended to ablate the right bundle branch, but those patients should need pacemaker or ICD implantation because the risk of AV block at follow-up is high due to the progressive Hesperkingi disease in those patients. Of course, ICD implantation is recommended if the patient has sustained monomorphic VT or aborted cardiac arrest not caused by bundle branch reentrant VT, unless he would have catheter ablation, and patient without AV conduction delay but they have a syncope, highly suspicious for ventricular arrhythmias, ICD is still indicated as a class 2A. And if the patient is having palpitation, highly suspicious for ventricular arrhythmia, and during the AP studies he had induction of non-bundle branch reentrant VT, ICD is still indicated because here it is a scar-related VT and there is no role for ablation. And in patients with limb-girdle type 1B or Emery-Dreyfus muscular dystrophy and they have an indication for pacing, ICD implantation should be considered due to the high risk for ventricular arrhythmias. And ICD is class 2B in patients with myotonic dystrophy if they have additional risk factors like advancing age, family history of sudden death, ECG conduction abnormalities, atrial arrhythmias, non-sustained VT, or LV dysfunction or structural abnormalities in CMR. In patients with Duchenne or Becker muscular dystrophy, the indication of ICD is only class 2B for those with significant late gadolinium enhancement at CMR, as the benefit of ICD here should be balanced against the overall prognosis as we mentioned before. And the big no for neuromuscular disorders is that serial EP evaluation of AV conduction and arrhythmia induction during an EP study is not recommended without any suspicion of arrhythmia or any progressive ECG conduction disorders. And this diagram summarizes the indications of ICD or pacemaker or catheter ablation in patients with myotonic dystrophy. For the sake of time, I'm not going in depth in this flowchart. And now let's move to the inflammatory heart diseases, starting with myocarditis. As we know, the diagnosis of myocarditis is challenging because there are no pathognomonic clinical presentation of the disease, with cardiac manifestation ranging from sometimes subtle symptoms up to severe heart failure, up to complete AV block, or even sudden cardiac death. And it is estimated that 2 to 12% of sudden cardiac deaths in young population are related to myocarditis. Although endomyocardial biopsy is not widely used, it is still considered the diagnostic gold standard for myocarditis. However, in current practice, the diagnosis of myocarditis relies on clinical presentation, elevated troponin level, ECG changes, LV dysfunction in echocardiography or CMR, and the absence of significant coronary artery diseases or valvular heart diseases, plus suggestive finding on CMR or PET-CT scan. The treatment depends on the clinical stage of the patient. For example, those with mild heart failure should avoid exercise and start beta blockers and ACE inhibitors. Those with fulminant myocarditis or those with ventricular arrhythmias or AV block should be admitted, and better to be referred to a specialized center with the capacity to perform catheterization, endomyocardial biopsies, mechanical circulatory support, and managing complex ventricular arrhythmias. And the ventricular arrhythmias per se does not differ in patients with inflammatory heart disease from the generally accepted clinical principles for treatment. The clinical fate of myocarditis can be divided into resolving without sequelae, or recurrence, or sometimes becoming chronic myocarditis leaving scarring in the myocardium. In this case, it is a precursor for dilated cardiomyopathy, as in 21% of patients over a mean follow-up period of 3 years they develop LV dysfunction. The exact proportion for chronic dilated cardiomyopathy secondary to acute myocarditis is still unknown. However, myocarditis has been identified as a cause of dilated cardiomyopathy in up to 12% of cases in a large retrospective study. That's why patients with sustained monomorphic VT of unclear etiology with LV dysfunction, myocarditis should be suspected, especially if CMR showed subepicardial and or intramural fibrosis. And so the management of ventricular arrhythmias in chronic myocarditis is the same as in dilated cardiomyopathy. The indication for secondary prevention ICD is in patients with hemodynamically not tolerated VT occurring in the chronic phase. It is class 1 indication, or hemodynamically tolerated in the chronic phase, but it is class 2A. And also, it is class 2A if there is hemodynamically not tolerated VT or VF during the acute phase of myocarditis. This is the only indication for secondary prevention ICD for the acute phase and before hospital discharge. The use of antiarrhythmics, preferably amiodarone or beta blockers, is in patients with symptomatic non-sustained or sustained VT during the acute phase of myocarditis, and in post-myocarditis patients with recurrent symptomatic VT. In this case, antiarrhythmics is indicated. The role for catheter ablation is in patients with recurrent symptomatic sustained monomorphic VT or with recurrent ICD shocks in whom antiarrhythmics are ineffective, not tolerated, or not desired. And the catheter ablation is class 2B in those with hemodynamically well-tolerated sustained monomorphic VT in the chronic phase, preserved LV function, and limited scar, which is amenable to ablation but still Class 2B as an alternative to ICD therapy, as in one publication VT non-inducibility after ablation led to the avoidance of ICD implantation in 33% of patients with subsequently no VT recurrence during follow-up. What about cardiac sarcoidosis? It is a multi-system inflammatory disease with a genetic predisposition with the accumulation of T lymphocytes, mononuclear phagocytes, and the famous non-caseating granulomas, leading to tissue scarring, and lung and lymphatic system are the most frequently involved organ, but it can affect any organ. Regarding the heart, 5% of patients develop symptoms indicated of cardiac involvement, which can be detected using CMR or PET CT scan. From this famous diagram, we can see that both monomorphic and polymorphic VT can occur, and the most common age of incidence is from 40 to 60 years of age. The straightforward indication for primary prevention ICD is for those with ejection fraction less than or equal 35%, the same as in patients with ischemic LV dysfunction. And if the patient is having ejection fraction more than 35%, who have minor late gadolinium enhancement at CMR after resolution of the acute inflammation, here programmed electrical stimulation is recommended for risk stratification. And if the patient had inducible sustained monomorphic VT, in this case ICD implantation is indicated. But if the patient is having significant late gadolinium enhancement after resolution of the acute inflammation, for example affecting 9 or more segments or more than or equal 22% of the LV mass, in this case ICD implantation is recommended even if the ejection fraction is more than 35%. And regardless ejection fraction, patients who have an indication for permanent pacing related to high degree AV block, ICD is a pacemaker of choice here regardless LV ejection fraction due to the high risk for ventricular arrhythmias and sudden cardiac death. Regarding secondary prevention, patients who have documented sustained VT or aborted cardiac arrest, they have a clear indication for ICD implantation, and if they are having recurrent symptomatic ventricular arrhythmias, antiarrhythmic drugs are indicated. And of course, catheter ablation in specialized centers is indicated in recurrent symptomatic VT or recurrent ICD shocks in which antiarrhythmics are ineffective, contraindicated, or not tolerated, and this is class 2B. This flowchart as well summarizes the indications for ICD or antiarrhythmics or catheter ablation in patients with cardiac sarcoidosis. I am not going to explain it in detail for the sake of time. What about the peculiar Chagas disease? It is caused by the protozoan Trypanosoma cruzi and is the most common cause of non-ischemic cardiomyopathy in Latin America. That's why we don't usually see it in the Middle East. After an incubation period, the majority of infected persons have minor or no symptoms at all, and just less than 1% develop acute myocarditis. But people are infected for life, and years to decades after the initial infection, 20 to 30% will develop cardiomyopathy, which can result in heart failure, AV block, atrial and ventricular arrhythmias. And unfortunately, sudden cardiac death is the most common cause of death in Chagas disease. There is a question mark about the role of ICD in Chagas disease. In a famous meta-analysis of observational studies, and we can find its link in the description below the video, there was no benefit of ICD versus amiodarone for the secondary prevention of sudden cardiac death, and the all-cause annual mortality rates were comparable in both groups. And in another meta-analysis, it found 4.7 annual incidence of inappropriate shocks and 9% annual mortality rates in 1,041 ICD patients with Chagas disease. That's why amiodarone has a class 2A to reduce the burden of arrhythmias in patients with Chagas disease who present with symptomatic PVCs or VT, and patients who have recurrent symptomatic sustained monomorphic VT or ICD shocks in which antiarrhythmics are ineffective, contraindicated, or not tolerated. Catheter ablation is class 2A. Just class 2B for those with symptomatic VT if the antiarrhythmics are not effective or not tolerated. In this case, we think of ICD So the clinical benefit of ICD treatment needs to be assessed in prospective trials in those with Chagas disease to have a strong recommendation for ICD implantation. The last group of diseases we are going to discuss today are the valvular heart disease. Of course, we know that sudden cardiac death may occur before surgery due to the latent LV and or RV dysfunction, and sometimes after surgery, for example, due to scar-related re-entry, as the rates of sudden cardiac death in patients with prosthetic valves range from 15 to 30%, with an annual risk of 0.2 to 0.9%, and sometimes residual LV dysfunction after valve replacement or valve repair sometimes may result in VT, and those who undergo ICD implantation have still appropriate therapy and mortality rates similar to patients with ischemic or dilated cardiomyopathy. That's why patients with persistent LV dysfunction after surgical correction, ICD implantation is a class 1 for primary prevention, as the same recommendation of dilated or hypokinetic non-dilated cardiomyopathy that we summarized at the start of this video, and in patients who have aortic valvular disease and sustained monomorphic VT, we should arrange for programmed electrical stimulation with standby catheter ablation to ablate bundle branch reentrant VT, which is common to occur after valve intervention. There is a common debate regarding the incrimination of mitral valve prolapse in the sudden cardiac death. It was reported in about 0.2 to 0.4% of those patients per year, and in recent pathological and clinical studies of sudden cardiac death victims with mitral valve prolapse, it provided some insights into potential substrate for ventricular arrhythmias. For example, major valvular disjunction and posterior systolic curling can result in excessive mobility of the mitral valve apparatus, resulting in mechanical stretch and fibrosis affecting the infrabasal LV free wall and the papillary muscles. This can result in ventricular arrhythmias. That's why CMR with gadolinium is recommended in those patients with mitral valvular disjunction to assess the extent of scarring. And as we can see in this diagram, and we can find the link for it in the description, that mitral valve prolapse sometimes may result in sudden cardiac death due to the interaction of the substrate with the trigger and sometimes transient modulator like hyperadrenergic state or electrolyte disorders. So in some group of patients there is a risk, but not in all patients. That's why there is a famous terminology called arrhythmogenic mitral valve prolapse syndrome, with a criteria for increased risk for sudden cardiac death, including young adults, most often women, QTC prolongation and or negative T-wave in inferior ECG leads, mitral annular disjunction on echo, bileaflet involvement, frequent PVCs or non-sustained VT on Holter monitoring and or exercise testing, reduced LV ejection fraction or detection of fibrosis on CMR, but so far there are no available recommendations for risk stratification or for ICD implantation in patients with mitral valve prolapse. But pay attention to these risk factors, because in some cases you need to have more frequent follow-up of this patient. Now, in brief, in some specific situations like ventricular arrhythmias during pregnancy, we should know that pregnancy and postpartum period can contribute to a significant risk in women with already arrhythmic heart disease. And new onset VT may present during pregnancy for the first time. Sometimes risk of recurrent VT is higher in patients, of course, with previous VT or structural heart disease, and you should rule out peripartum cardiomyopathy in case of new onset VT in the last 6 weeks of pregnancy or the early postpartum period. So it is not uncommon to see ventricular arrhythmias during pregnancy or postpartum periods. We all know that electrical cardioversion is recommended for sustained VT during pregnancy. It is safe in all phases with no compromise in fetal blood flow or risk of preterm labor, but assess the fetal rate routinely after cardioversion. And for acute conversion of hemodynamically tolerated VT during pregnancy, we can use beta blocker, sotalol, flecainide, procainamide, or use overdrive ventricular pacing. Regarding long-term management, if ICD is indicated during pregnancy, it is recommended with optimal radiation protection. Continue beta blocker in case of pregnant females with already diagnosed long QT syndrome or catecholaminergic polymorphic VT or arrhythmogenic RV cardiomyopathy. So far, there is no additional risk by pregnancy in women with Chagas syndrome. We can use metoprolol, propranolol, or verapamil for long-term management of idiopathic sustained VT during pregnancy, and catheter ablation sometimes is indicated for recurrent sustained monomorphic VT refractory to antiarrhythmics or not tolerated, but using non-fluoroscopic mapping to reduce radiation exposure and better to be after the first trimester for highly symptomatic patients. So the antiarrhythmics that are well tolerated during pregnancy are sotalol and oral verapamil. The antiarrhythmics that are well tolerated during pregnancy are sotalol and oral verapamil. Some can be used if potential benefit more than potential risk, like most of the beta blockers except atenolol, digoxin, IV verapamil, diltiazem, but with some possible teratogenic effects, diazepamide, flecainide, lidocaine, or quinidine. Inadequate data, so better to be avoided ivabradine, mixilitine, propafenone, which is a common medication to be used here, and vermicellins, and contraindicated use amiodarone, atenolol, or dronidarone. For those awaiting heart transplantation or after those awaiting, ICD has a class 2A for primary prevention in patients on the waiting list for transplantation, and wearable cardioverter defibrillator has just weak evidence as class 2B. After transplantation, selected patients with cardiac allograft vasculopathy or treated rejection have the class 2B for ICD implantation. And the last situation to be discussed today is the ICD in elderly. The problem that in those patients sometimes the benefit from ICD is not expected due to the age and comorbidities. In this case, there is a class 2B for omission of ICD for primary prevention, but after careful clinical assessment. Here we cannot use a simple age cutoff, but we should have a careful assessment of biological age versus frailty index, so we should consider the overall condition, comorbidities, functional capacity, and life expectancy to decide whether this patient will benefit from ICD or not. So we have reached the end of our video today, which is the last video in the guidelines of ventricular arrhythmias. So what we discussed today, the LV non-compaction cardiomyopathy, restrictive cardiomyopathy, and especially cardiac amyloidosis, neuromuscular disorders like myotonic dystrophy and Duchenne Becker, inflammatory heart disease including myocarditis, cardiac sarcoidosis and Chagas disease, valvular heart disease with emphasis on the arrhythmogenic mitral valve prolapse syndrome, and the situations of ventricular arrhythmias during pregnancy, before and after heart transplantation, and the ICD decision in elderly. Thank you very much for watching this video, and you can check the links for these topics in the description below the video. And thank you very much for continuing this journey throughout the guidelines of ventricular arrhythmias through 14 videos. I enjoyed all of them with you, and waiting for your comments and waiting for another guidelines to discuss on Cardiomyopathy channel.